Давайте перезагрузим.
Все, началось. Hello, dear students. We continue our lecture. Let's start. Our lecture today, Соломатина Надежда Николаевна, and our theme of this lecture, periodontitis. The urgency of treatment of various forms of apical periodontitis is caused by its significant prevalence. At present, the complication of caries in the form of chronic apical periodontitis, especially in the adult population, is one of the main dental and social problems. The number of patients with this pathology is 35% of the total number of people who need dental treatment. A significant prevalence rate of chronic periodontitis is associated with low efficiency of dental periodic health examination among the adult population, inadequate quality of mass dental care, and sanitary and educational work among the population. Periapical foci of infection in 5 or 6% of causes are the cause of tooth extraction, a source of chronic intoxication, sensitization of the body, etiological factor of odontogenic sepsis, mediastinitis, intracranial inflammation, phlegmon of the maxillofacial region. Well, what is the periodont? It is a periodont. It is a connective tissue formation that is found in the closed space between the alveolar wall and the root cement. The width of the periodontal gap is not the same in different sites. At the neck of the tooth, its width is the greatest. Is the greatest on 0.3 or 5 millimeter. At the top of the root, it's on 0.25 millimeters, and in the middle part, it's on 0.5 or on 0.2 millimeters. And the size of the periodontal gap of the incisors is much larger than that of the molars. Periodontal aperture is greater on the lower jaw than on the upper jaw. A source of periodontal innervation, second or third branches of the trigeminal nerve. Let's tell about periodontal functions. The first, supporting the tooth retains in the alveolar socket. The second, amortizing, it distributes the chewing load. The third, plastic function. And the fourth, trophic function. It nourishes the tooth tissues, participates in teeth growth and eruption. Periodontitis is inflammation of the periodontal tissue in the tip of the root. In contrast to periodontium, it's inflammation of the tissues surrounding the root of the tooth. Ways of infection penetration in periodontal apertures. The first, infections through the root canals, macro and micro channels, through the periodontal pockets. The ligament of the tooth is destroyed with blood flow. The second, toxic. The second way is toxic overdose of potent drugs during root canal treatment. The third way, traumatic way, overload of periodontal tissues, acute or chronic injury. For example, fracture of the tooth crown, tooth injury. Classification. When making the diagnosis, many physicians use the clinical classification of periodontitis, NMC, and the International Classification of Dental Disease, ICD-10. Thanks. In this slide, you can see a classification of periodontitis according to Lukomsky. The first form, acute periodontitis, it may be serous or purulent. The second form, chronic periodontitis, it may be fibrous form, granulating form, and granulomatous form. The third form, aggravated chronic periodontitis. This slide shows NMC classification. Periodontitis can be acute, apical and marginal, chronic, fibrous, granulating, granulomatous form, and aggravated chronic periodontitis. In case of acute, serous and purulent periodontitis, patients clinically complain of severe pain. The pain gradually increases. It also increases with nibbling. The following aspects characterize acute periodontitis. The causative tooth is intact or under the seal. The color of the tooth is changed, grayish. The enamel doesn't shine. The mucous membrane of the oral cavity is hyperemic and endomatous. Accumulated exudate needs a way out. If there is no exudate outflow, then it will go either along the periodontal gap under the gum and form a subgingival abscess, or through the bone tissue under the periosteum and form a subperiosteal abscess. If trypan, the tooth crown is trypaned or the seal is removed, the exudate can go out through the root channels into the tooth cavity. This is the safest way. The worst case is if exudate goes into the bone body. In this case, osteomyelitis can develop. When examining a patient, dentists use the following methods. Probing of the caries cavity. In this slide, you can see a picture, and in this picture shows Probing of the carier's cavity. Probing of the carier's cavity, which does not open into the tooth cavity in case of acute and aggravated chronic periodontitis, is painless. Tooth percussion in case of acute and aggravated periodontitis is painful. In this slide and in this picture you can see a palpation and thermometry. Thermometry is painless in all forms of periodontitis. Palpation, the picture left. Palpation of the transitory fold is painful in the case of acute and aggravated chronic periodontitis. Lymph nodes can be painful as well. Electroodontal diagnosis and X-ray are also used to estimate the periodontal stability threshold. It's necessary to identify the condition of the bone tissue surrounding the root of the tooth, determine the number of roots and canals and channels, the anatomical features, the state of the bone tissue of the interdental partitions, tooth inclination, and the obstruction quality if the treatment was performed earlier. The röntgenogram shows one of the forms of periodontitis. In case of chronic fibrosing periodont, patients don't complain of pain. They complain of the carier's cavity. The most aggressive form is granulating periodontitis. In case of this form of periodontitis, the patient complains of heaviness, discomfort in the area of the affected tooth, and slight pain with numbing. In case of chronic granulation and granulomatous periodontitis, fistulous passage can occur in the projection of the causative tooth root. Tooth percussion is painless. Probing of the carier's cavity, which opens into the tooth cavity, and probing of the channel, orifice, and are painless. Palpation of the transitory fold is painless as well. The aggravated chronic periodontitis looks like acute periodontitis, but when probing the tooth cavity, the physician discovers that the carier's cavity opens into the tooth cavity and the pulp is lost. If the patient does not undergo any treatment, the inflammatory process can spread to supporting tissues. Periosteitis, osteomyelitis, colorful cysts, abscess, phlegmona can develop. Treatment of acute and aggravated chronic periodontitis. It's necessary to give an exudate outflow and to stop the pain. Anesthesia is administered. It sometimes immediately brings relief. Then dentists perform trepanation of the tooth if it's intact. If there was any previous treatment, the seal is removed and channel orifice is opened. In such a case, purulent or hemorrhagic exudate can go out. Next, instrumental processing of the root channel is performed. It's washed and left open until the next visit. With severe edema and high temperature, antibiotics are required. Lincomycin for 5 days. It's necessary to prevent further spread of infection deep into tissues, to remove pulp, degradation from the tooth cavity and root channels. Then the dentist should penetrate into and expand the channel of the tooth root. Today, root channel treatment includes different steps: step back, crown down, file, rimmer, and profile. Then dentists irrigate the root channel with 3.25% sodium hypochlorite solution using an endodontic syringe, and then dry it with a paper absorption pin. It's important to create favorable conditions for the reverse development of the inflammatory process. For this purpose, create a drug depot in periodont. To improve the protective properties of periodont, apical therapy is carried out. Immunostimulants are used. Grinazole, Metatex, Metapasta, iodix from 2 weeks up to 6 months. In our country, electrophoresis with a solution of 10% potassium iodide was widely used. Good results were achieved under complete obturation of the root channel. P.L. Lels and N.D. Itzbekova in 1997 he reported that the introduced ions remain for 24 hours and then their concentration was sharply reduced. Taking this fact into consideration, Knapvost developed a fundamentally new method, namely dephoresis with copper calcium hydroxide. This method has 3 fundamental differences from previously used one. First, it's not the ions that are administered into the channel, but the molecules of copper calcium hydroxide, which have a pronounced antiseptic effect and create a depot in the root part. The second, the drug administered into the root channel gets to the root surface through the branching and stimulates the physiological closure of the opening on the root surface, and the lower third of the channel is not to be sealed. And the fourth, the dentist should carry out root channel obstruction, the method of one central pin, lateral condensation method, lateral condensation of gutta percha with the scalar method of introducing gutta percha on the curved thermophile. And we must restore the anatomical shape and physiological function of the tooth with dental restoration. In this slide shows the patient's control X-ray image after root channel obstruction with paste, when the paste is removed above the top of the root channel. The paste goes along the fistulous tract. If after root channel obstruction the patient complains of pain, the dentist should prescribe high-frequency therapy, electrophoresis with analgesic, anesthetizine, novocaine, inherent light therapy with red light. What do you think? What can a general practitioner do? He do treat the patient's mucous membrane with the 35% solution of tincture of iodine. Prescribe soda bath after cleansing of abscess, if any. Assign physiotherapy. Patient should be sent to the dentist. That's all about treatment periodontitis. Thank you for your attention, and we continue our lecture. Wait a bit, please. And the next topic of our lecture, disease of periodont. The term periodontium implies a complex of tissues that surround the tooth, gum, periodontitis, bone with periosteum and tooth. Diseases of periodont and characterized by inflammatory and dystrophic process. Disease of periodont are a common problem. This can be explained by the following factors. The first, now physicians observe significant prevalence of periodontal lesion. Those, according to the WHO, 100% of adults and 8% of children have some signs of periodontitis. This disease can be called the disease of the century. The second, this pathology leads to a significant loss of teeth. The third, diseases of periodont contribute to chronic infection, which reduce the resistance of the body and disease development. The etiological factors are known to be the main causes of periodontal pathology. This allows us to prevent and treat inflammatory disease. Nominally, the causative factors are divided into local and general, taking into consideration that are closely interrelated and interact with the body and the environment. It is known that inflammation is caused by infections, chemical, physical, mechanical, and immunogenic, and other factors. In this slide, you can see classification of disease of periodont. The first form of disease, gingivitis. Gingivitis is the inflammation of the gingiva of the alveolar portion as a result of adverse effects of local and common factors. This disease does not influence the integrity of the dentogingival junction. Forms of gingivitis. The first, catarrhal form. The second, hyperotic, ulcerative. Heaviness, light or medium or heavy. Heaviness. Development of disease may be acute, chronic, or aggravated form. The second form of disease of parodont is parodontitis. Parodontitis is an inflammatory dystrophic process characterized by progressive destruction of periodontal and bone tissue of the alveolar portion. Development of disease: acute, chronic, or aggravated form. Disease in incidence: generalized. The third form of disease of parodont is parodontosis. Parodontosis is a generalized chronic dystrophic process. Development of this disease: chronic and remission development. Disease severity may be light, medium, and short disease severity. Disease incidence: generalized form. The fourth form of disease of parodont is idiopathic disease with progressive disease of periodontal tissue, keratoderma, for example, Scheuer-Christian disease, papillon Lefevre syndrome, neutropenia, and uncompensated diabetes mellitus. The fifth form of disease of parodont is parodont tumors. Tumors and tumor-like disease, epulis, fibromatosis, for example. While examining the patient, orthopathomography is always necessary. According to WHO, the primary cause of gingivitis is the bacterial plaque, which promotes the formation of supragingival dental plaque. Insufficient self-cleaning of teeth in unsatisfactory dental care, qualitative and quantitative changes in the oral fluid contributes to formation of dental plaque. For normal parodont, natural self-cleaning is not enough. It's necessary to brush teeth with a toothbrush, reducing the saliva amount. If salivation or xerostomia decreases the mechanical removal of food residues. In addition, the protective function of saliva decreases as a result of lysozyme, lipase, and immunoglobulin decrease. Other etiological factors of the periodontal inflammatory processes are mechanical factor, seal, crown, planar prosthesis, etc. Chemical or physical damage of the mucous gum. Risk factors, anomalies and deformations of the jaws, dental crowding by abnormalities, etc. A small vestibule of the mouth, a short attachment of the labial and tongue frenulum. Predisposing factors are endocrine diseases, diabetes mellitus, Itzenka-Cushing disease, hormonal dysfunction of the reproductive system, etc. Necrosomatic disease, oligoproteinuria, rheumatism, metabolic disorders, or nephropathy, etc. It should be borne in mind that all systemic disease change the reactivity of the organism and contribute in a greater or lesser extent to the one-central progressions of inflammatory and dystrophic process. Wait a bit, please. We are returned. Lack of vitamins, pathology of the gastrointestinal tract and cardiovascular system, etc., contribute to the development of periodontal disease as well. Yevdokimov proved that one of the first morphological signs of the disease is the atherosclerotic lesion of a small blood vessels in the tissues around the teeth. Platonov claimed the dystrophic change in the periodont tube are the result of trophic disturbance of the central or peripheral parts of the central nervous system. Novik and Danilevsky consider periodontitis as a manifestation of tissue neurodystrophy. The form of disease of periodont is gingivitis. Acute catarrhal gingivitis form is an acute exudative gingival inflammation. Hyperemia, edema, bleeding, pain. Dysfunction of the dentofacial apertures. At an early stage, the age of a gum is involved. At a moderately severe stage, the immobile gum of an alveolar portion of the jaw and the interdental papilla are involved. At a severe stage, the diffuse inflammatory process is observed in the whole gum. Chronic catarrhal gingivitis is characterized by gum hyperemia with a cyanotic shade of varying intensity. It also has high degrees of severity. In case of aggravation of chronic catarrhal gingivitis, the clinical picture looks like an acute process. Hypertrophic form. Hypertrophic gingivitis is a chronic proliferative inflammation of the gum, which is accompanied by proliferation of connective tissue and the basal layer of the epithelium. There are granulating edematous and fibrous forms. The edematous granulating form of gingivitis is characterized by hyperplasia of the gingival papilla, hyperemia with cyanosis, quaggy tissue, bleeding, and formation of false gingival pockets. Fibrous form is characterized by nodosity of gingival bases. Interdental papilla are hyperplastic, rounded, gingiva is dense, no bleeding is observed. The gingiva is pale pink. There are no false gingival pockets. At an early stage of aggravation, dentists observe the growth of the gingival edge and gingival papilla in the form of a platen. They go up one past 3 of the tooth crown, and at the moderately severe stage there is hypertrophy of the gingival, margin, and papilla up to 1/2 of the tooth crown. At a severe stage, the tooth crown is covered with an overgrown tissue by 2/3. The rentgenogram shows osteoporosis. And the next form of gingivitis, hypertrophic gingivitis. This gingivitis often occurs in adolescence, pubertal period, in pregnant women, in patients with epilepsy, chronic disease, decreased thyroid function, leukemia, vitamin C deficiency, and acid gastritis. Treatment is usually symptomatic. The next form, ulcerative gingivitis, will be considered later in the section oral cavity mucosal disease. Parodontitis. Parodontitis is an inflammatory dystrophic process of periodontal tissues which is caused by local and general fractures and characterized by diagnostic gingivitis, periodontal pocket, traumatic occlusion, resorption of alveolar bone. Clinical features of periodontitis. The severity of the pathological process and its development depend on the overall condition of the body, its resistance. In a mild case, physicians can observe chronic lateral hypertrophic gingivitis. Periodontal pocket are 3 or 4 millimeters with serous drainage. First degree pathological tooth mobility. The process is limited. The rentgenogram shows the destruction of the compact plate on the toe of the interdental septum, resorption of the alveolar bone up to 1/3 or 1/4 of the interalveolar septum, widening of the periodontal gap in the cervical region. In a modern case, dentists observe mild or moderate lateral or hypertrophic gingivitis. Periodontal pockets are of 4 or 5 millimeters with serous drainage, first or second degree of tooth mobility. The rentgenogram shows resorption of the alveolar bone up to half of the interalveolar septum. In an aggravated case, patients demonstrate diffuse symptomatic gingivitis, marked traumatic occlusion, second or third degree of tooth mobility. Periodontal pockets are more than 6 millimeters with purulent drainage. The rentgenogram shows progressive resorption of the alveolar bone up to 2/3 of the interdental bone septum. bone pockets can be formed. In this you can see aggravated case. In case of the inflammatory process, symptomatic gingivitis, catarrhal hypertrophic or ulcerative, is observed in the periodontal tissues. Teeth lose their stability, become mobile. Subgingival abscess of periodontal pockets can often be observed. Moreover, patients demonstrate symptoms of general intoxication, fever, discomfort, or headache, for example. Radiographically, you can see physicians can distinguish severe osteoporosis in the interdental septa and uneven vertical resorption with the formation of bone pockets. Especially significant foci of osteoporosis are seen in the areas of abscess formation. The periodontal gap is widened to a large extent. And the next, parodontosis. Parodontosis is a generalized chronic dystrophic process characterized by gum atrophy, exposure of the tooth, necks, and roots, increased sensitivity of tooth hard tissues, slowly progressing resorption of the alveolar portion. The disease progresses slowly and can develop for many years. Clinically, you can see the gum is pale, atrophied, the gingival papillae are smooth, the interdental spaces are vivid, the periodontal pockets are not observed, as gingival atrophy and resorption of the alveolar process develop. There appear traumatic occlusion and wedge-shaped defects. So pathological tooth mobility is determined only in a severe case. In this, you can see clinic. Horizontal resorption of the alveolar bone is seen on the X-ray image. The remaining alveolar bone has a pattern of a spongy substance. The interdental septa are informing, truncated at different levels, depending on the degree of the disease. Treatment. It is very difficult to treat parodontitis. But in this picture shows a horizontal resorption of the alveolar bone. It is orthoparodontography, orthoparodontogramma. And in this picture shows parodontosis. Treatment of parodontosis and parodontitis. It's very difficult to treat parodontitis and periodontosis. Throughout the world, therapy is aimed at achieving a more stable remission. It's impossible to cure this disease completely. Famous professor and periodontologist Gruziano A.E. note that inflammatory process of periodontal tissues are characterized by a variety of clinical manifestations, active development and severity for the dental jaw system, the complexity of optimal therapeutic agents and complexes. Treatment of periodontal atrophic treatment aimed at eliminating the causative factors. The second, pathogenic therapy using methods and means of influence on the inflammatory dystrophic process in the periodontium. The third, symptomatic therapy which strengthens protective and adaptive mechanisms. The fourth, restorative treatment includes rehabilitation. The main requirements for therapy treatment should be complex. It implies therapeutic, surgical, orthopedic, and physiotherapeutic impact on the focus in the periodontium and on the body as a whole. Strict, individualized, complex therapy should take into account the form, severity, the clinical development of the disease, as well as the general state of the body. The choice of methods and means should be justified in each specific case. Treatment begins with removal of the supra and subgingival dental calculus. Drug-induced anti-inflammatory therapy is performed to activate metabolic and reparative process. Physical factors are used. When necessary, surgical treatment, curettage of the periodontal pocket, flap surgery, orthopedic treatment, occlusion balancing by grading the cutting and shaving tooth surface, which fix the dental prosthesis. Patients with periodontal disease should undergo periodic health examination. Patients with idiopathic disease should be sent to a therapist. In this you can see parodontoma. Mucosal diseases of the oral cavity. The mucosal diseases of the oral cavity and prolabin are very important in modern dentistry and dermatology, despite the fact that they constitute a small part of the dental diseases. However, it's very difficult for a doctor to make a precise diagnosis. On the one hand, it's due to the variety of the oral cavity disease, and on the other hand, it's preconditioned by the similarity of clinical manifestations of such disease, which are different in etiology and pathogenesis. However, it's very difficult for a doctor to make a precise diagnosis. On the one hand, it's due to the variety of the oral cavity disease, and on the other hand, it is preconditioned by the similarity of clinical manifestations of such diseases, which are different in etiology and pathogenesis. However, the nature of changes in the mucous membrane largely depends on the localization of the pathological processes, the age of the patient, his or her, the general condition, etc. Despite significant achievements in the study of the cause, etiology and pathogenesis of mucosal diseases of the oral cavity, their causes remain unclear. Currently, mucosal diseases of the oral cavity are considered from the standpoint of a whole organism because no one doubts that the majority of pathological processes on the mucous membrane of the oral cavity and prolabio are connected with the changes in the organs and systems of the body, the nature of metabolic processes, patient's immune status, etc. Changes in the mucous membrane of the mouth are often the first clinical symptom of metabolic disorder, disease of the hematopoietic system, skin and venereal diseases, etc. There are many different classifications of the mucosal disease of the oral cavity and prolabium. Stomatitis makes up one of the groups. Let us consider some types of stomatitis. Catarrhal stomatitis. This is the mildest form of the mucosal inflammation of the mouth cavity, which can often be limited to gum inflammation or include to the entire oral mucosa. Local factors that cause the development of the disease are dental calculus, multiple caries, absence of oral hygiene, mucosal trauma, exposure to drugs, chemicals, etc. Catarrhal stomatitis often occurs against eating disorders, diseases of the gastrointestinal tract or other body systems, dysbacteriosis of the oral mucosa, and the gastrointestinal tract. It accompanies childhood infection, inflammatory processes in the nasal cavity or in the ear, etc. Clinical sign of the disease is mucosal hyperemia. It becomes very bad and quaggy. Patients often complain of dry mouth or hypersalivation. The mucous membrane becomes painful even with a slight touch. When the process spreads to the entire mucosa, regional lymph nodes are enlarged and painful. Catarrhal stomatitis is often the initial form of other mucosal diseases of the oral cavity. Secondary infection causes are more severe form of stomatitis, or the disease can become chronic. Diagnostics is usually rather easy. It can be difficult only in case of concomitant systemic disease or if the physician observes the chronic development of the illness. In these cases, clinical and laboratory tests and special studies are carried out. Treatment. First of all, it's necessary to eliminate the possible cause of the disease. The mucosa should be treated with antiseptics, dyes, and antibiotics. In certain cases, symptomatic therapy is to be used. protective diet should be prescribed. If the process doesn't stop, the physician should look for a common cause and conduct a local and general treatment. Ulcerative or ulcerous necrotic stomatitis. This is an acute inflammatory disease of the oral mucosa. Clinical picture. During the prodromal period, patients complain of discomfort, subfebrile temperature, headache, and burning in the mucosa. In 2 or 3 days, multiple ulcerations appear on the hyperemic mucosa rather quickly. They emerge and are usually covered with necrotic elements of dirty gray color. In case of the removal, the ulcerated surface is exposed. There appears putrefactive smell from the mouth. The temperature rises, regional lymphadenitis is observed. The intake of food is tempered due to the sharp mucosal pain. Hypersalivation is also noted. At first, the gingival edge is affected. Then the whole oral mucosa is involved in the process. At the same time, the temperature is 38-39 degrees of Celsius. The patient is intoxicated and pale. The lymph nodes are callous and painful. Blood modulates growth of ESR and leukocytosis is observed in the blood. Ulcers have soft, uneven, crater-like edges. They are covered with a thick necrotic deposit of dirty green color, which is easily removed. The mucosa around is hyperemic and edematous. So, treatment. Ulcerative gingival stomatitis requires local and general treatment. General treatment involves broad-spectrum antibiotics, desensitizing drugs, metronidazole, tinidazole, vitamin C and P, high-calorie diet, juices, and physiotherapy. Local treatment. The necrotic plaque is removed. The ulcerated surface is treated with antiseptics, proteolytic enzymes, anti-inflammatory therapy, and keratoplastic drugs are prescribed. The damaged areas are treated with oxycodone aerosol, disinfecting and deodorizing agents are used. Solution of ramazulan, sage, chamomile, etc. Ultraviolet irradiation, red light emitting diode emission, phonophoresis, and medicinal drugs. The prognosis is favorable with correct treatment. The recovery is expected in 7 or 10 days. Acute herpetic stomatitis. It is an infectious disease caused by the herpes simplex virus. Infection is transmitted to a person by contact or airborne. This disease often occurs in children from 6 months to 3 years old. Adults can also suffer. The disease is more severe. Hypothermia, defatigation, systemic disease contributes to its development. Development of the disease. There are 5 phases. The first, incubative phase, the second, prodromal phase, the third, eruptive, the next, involution phase, and recovery phase. The clinical progression depends on the activity of the virus and the immunological status of the patient. The development can be mild, moderate, severe. Mild. The mucous membrane is hyperemic. There appear follicles on it, which burst quickly, and physicians can observe apathy with a red rim. The temperature is up to 37.5 degrees of Celsius. The general condition is satisfactory. In 3 or 5 days, the lesions are epithelialized. Moderate. The general condition of the patient is unsatisfactory. Patients complain of weakness, headache, discomfort, disturbance of sleep, and appetite. The lymph nodes are enlarged. The body temperature reaches 38.5 degrees of Celsius. Multiple follicles appear on the hyperemic mucosa. They burst very quickly, forming apathy. Apathy usually merge and can be covered with the grayish coating. The salivation increases in patients. Saliva is viscous. There can be rash on the face as well. The patients have accelerated ESF and leukopenia. If cause of microbial infection, leukocytosis can occur. Epithelialization of the affected surface begins in 5 or 7 days. A severe form of acute herpetic stomatitis is rare. The patient's organism is intoxicated, thus the body defenses decrease. The body temperature is more than 39 degrees of Celsius. Physicians observe lymphodensity. There can be seen multiple follicles on the mucous membrane. Apathy merge and become necrotic. There appears putrefactive odor from the mouth. Salivation increases, blending in the gum is observed. Moreover, the disease affects the skin of the face, ear lobes, and fingers. The disease develops 8 or 10 days. Often the function of various organs and systems can suffer. Contaginosis is rather high. Blood tests show leukopenia, leukocytosis, young forms of neutrophils, accelerated ESF. After acute herpetic stomatitis, the herpes simplex virus usually persists in the body. Under the influence of adverse factors, the chronic herpetic stomatitis recrudesces. The patient complains of burning pain, itching, and soreness of the mucosa. There appear follicles which burst, forming apathy. The salivation increases, the gums bleed, lymph nodes enlarge. Seasonality is known as aggravation of disease of internal organs. In case of a chronic disease, the incubation period is not observed. There are three stages in the clinical picture: mild, moderate, and aggravated. If the disease is mild, repeated bouts are observed 1-2 times a year. There can be 1-2 elements of damage. If the disease is moderate, repeated bouts are observed 3 or 4 times a year. In case of an aggravated form, repeated bouts are observed 5 or 7 times a year. Treatment is a difficult task for the doctor, as the virus exists in the body in a latent state, and it is not always possible to prevent a relapse. In the prodromal period, it's necessary to use drugs that produce interferon or contain it. 3% megacin ointment, 0.5 or 2% unguentum tebrofeni, or 1% unguentum florinali, 0.5% bonaptone, 2.25% oxalim ointment, 2% interferon ointment, and the next 2%, 5% albisarin ointment. Antiseptics are used to treat the affected zone: deoxydiline, chlorhexidine, or lizozim, etc. To speed up epithelialization, it's recommended to use keratoplastic drugs: methylacryl ointment, vinylin, vitamins A, E, D, resinhip, and C, buckhorn oil, etc. Medicinal herbs such as shalfei, hormilla, etc. are also used. Anti-inflammatory therapy includes indomethacin, orthopheno, naproxen, etc. In more severe cases, special immunotherapy is recommended: vaccinotherapy, immunoglobulin, measles virus gamma globulin, serum colostrum humana deputata vida. Physiotherapy, for example, ultraviolet irradiation, red light emitting diode emission, photophoresis, and medicinal drugs. Prevent measures don't allow employees to work during the recurrence of herpetic stomatitis in kindergartens and nurseries. The second, in dental clinics, it's necessary to have separate rooms to treat patients with viral disease. The third, don't allow children with the disease to go to any public institution. The fourth, daily examinations of children, the use of interferon, polyvitamins, general tonics, irradiation of rooms for children and children as well. Chronic recurrent ulcerative stomatitis. It's an inflammatory process with periodic after on the oral mucosa, usually observed in adults. The etiology is unknown. A number of authors believe that apathy appear in response to hypersensitivity to certain food products and medicines, or somehow connected with endocrine disorders, infections, diseases, hypovitaminosis, hereditary and constitutional factors, humoral and cellular immunity, as well as autophagy factors, have a certain value. A number of authors believe that it's caused by neurodystrophic changes associated with general vegetative disorder and certain disease of the digestive system. A number of local factors, such as contralateral metals in the oral cavity, or lack of oral hygiene, contribute to the development of the disease. That's all. It's the end of our lecture. Thank you for your attention. Goodbye, dear students.